Hi everyone, Dr. Michael Miyazaki here again, and today we are going to discuss one of the most important things that we do in our practice every day, almost every minute, and that is curing. Curing everything from cements to composites, hardening things that are in people's mouths, and if we don't get it right, we're going to have sensitivity issues, we're going to have patients complaining to us. So it's one of the most important things that we do, and we don't really think about it a whole lot. We take it for granted because it's just what a light. So what I want to go and do is just kind of discuss some of the main things about curing that will help you. One of the things that I recommend from Vista Apex is getting a high quality curing light, and Vista Apex has one called the PinkWave. It is a different curing light, but I'll go through some techniques. So if you don't have a PinkWave, don't panic. We'll still give you some tips that you can use. But if you can get your hands on a PinkWave, and they're kind of hard to get right now, I would highly recommend it. So one of the things about composites is kind of tricky is we cure it and it can be hard on the outside, but on the inside, like some really good sourdough bread, it can be soft. So you know how some of us like our sourdough bread kind of crunchy on the outside that you bite into it and you feel that crunchy crust, but then on the inside it's like warm and soft, and you put your butter in there and just like seam-free composite wetting resin, that butter just penetrates into all the nooks and crannies, and we have some really, really good, enjoyable bread, hopefully with a good glass of wine. But like composites, if we get the outside hard and the underside is soft, we're going to have problems. That composite restoration isn't going to last long. That composite restoration, when the patient bites down, is likely going to have sensitivity. And if we were using a resin cement and we thought we had cured it, well, that crown or that indirect restoration is probably going to come off. Probably most likely on a late Friday night, right about the time you're about ready to take your loved one to dinner or you're about ready to go to sleep. So we don't want that to happen. We want you to enjoy your life. So what we're going to do is we're going to go through some things that I think about when I'm curing. Some of the potential problems are very simple, like the wavelength of our lights, the intensity of our lights, shadowing. One of the things that I didn't really think about, because even our adhesive many times are light cured, and so it's very important that we avoid shadowing. So we'll talk about that. And then composite shrinkage. Now we all know that when composite cures, it shrinks, and when it shrinks, it can pull away from the tooth. And if it pulls away from the tooth, we can have gaps at the margin. That's not good. So one of the things that I have watched over the last almost 4 decades in practice is that when I first got my first curing light, we were taught that it had to be blue light. Why blue light? Because one of the most common photoinitiators at the time, the chemical that would cause the polymerization of our composites or hardening, was camphorquinone. And camphorquinone was right around that 420 to 450 nanometer wavelength of light, which was the blue light. And so the curing lights that we had were blue light curing lights. But then what happened was camphorquinone was kind of yellow, its natural color. And people now wanted bleached white composite restorations. And so the manufacturers began to come up with photoinitiators that were lighter in color. Makes sense. But they were different photoinitiators. They cured at different wavelengths. So now we started to get into the 350, 380 nanometer wavelength. So if you had your blue curing light, which was maybe 420 to 450, but your photoinitiator needed 380, you weren't in that wavelength. And so one of the things about curing something or causing something to polymerize, it's a chemical reaction. If we don't apply the correct energy, that energy is not absorbed and it doesn't facilitate the reaction. And that's why we can have a very bright light, but if it's not the right wavelength, we can end up with a material that doesn't cure. And so today what we try to do is we try to have these poly wavelength lights, meaning there's more than one wavelength, and so they can be kind of broad spectrum. And that is something that you should look for. Another potential problem was the intensity of the light is usually inversely proportional to the distance. So the further away it is from whatever you're curing, the weaker it is. And so what we have to do is we have to try to get our light to be right by whatever it is we're curing. And then we have to actually collimate it, which means when you turn a light on, like our light bulb above me, the light is just dispersed. Whereas some of you have seen laser lights and they're very precise, they don't spread out, they don't lose energy. And so with a curing light, we want to collimate it, meaning we want to have a pure beam of light that goes down, and we want that pure beam to be as close to that surface that we're trying to cure. And actually, we want it to penetrate. So something like the PinkWave, where a curing light like the PinkWave curing light is collimated so that we don't lose that intensity of the light as the distance increases. So if we didn't have it well collimated, it would just disperse the further it was away. So we try to hold it close to the surface. So we have that high intensity, but because the lenses are fabricated so that the light is well collimated, we don't lose the intensity of that light like you may with some other curing lights that are out there. Another potential problem is what we call shadowing. And that is that if I can't get the light to shine straight down my preparation so the light hits all the internal walls of my preparation, we may not cure, maybe our adhesive or maybe our resin-eluting cement or maybe even our composite that we place into that box form like we see here. So we have shadows. And the shadows in those areas are areas where whatever we're using that's light cured or takes light to cure, it won't cure in that area, and that's going to be a potential problem. So if I have like an old curing light where the head kind of curved and it wasn't like at a 90-degree, it wasn't a low profile light, and I was trying to get to first molar, second molar, sometimes I couldn't get that light directly over the occlusal surface of that posterior tooth, and I could create shadows. And those shadows were something that I didn't really think about. I thought the light just kind of filled up that space. The light doesn't do that. Light can't go through walls, and so we have shadows. If we're outside, the sunlight can't go through our body, so we have our shadows. A curing light works the same way. If there's something in front of that light before it hits the surface of the tooth, we have shadows. And so we want to have a curing light that is what we call low profile. I mean, I can get it all the way back there to the first molar, second molar, and even a third molar, and I can get my light to go straight down the preparation without having shadowing. So being low profile is important to me. Now, one of the other challenges is shrinkage, which means if I put a large volume of composite in a tooth, like a box of a class 2, and I cure that with my light, what happens is the composite, the top surface of that restoration cures first, and as the light penetrates through the composite further cures. But we know that composite shrinks, and so that part that is cured first kind of contracts a little bit. And then the parts below that then contract up a little bit. So what happens is our composite actually cures towards the light, which oftentimes means it's curing away from the tooth. And especially at the bottom of our box, we can have a microgap form there, and we don't want that. That little microgap is formed because of shrinkage. So this is a resin block, and I believe this was about 7 millimeters from occlusal down to the bottom of the box form. So here's our box that's cut out. This was filled with composite and then cured from the occlusal surface. So as the light began to penetrate through the composite, it hit the occlusal surface first, so this cured, shrunk up. Then the light went down a little bit deeper, so this area shrunk a little bit, pulled up. Then the light went down a little further, so this area shrunk, pulled up. And by the time you got to the bottom of this box, you actually got this microgap formation. And that's because everything above this area shrunk up. Now the walls don't look too bad, but you can definitely see this microgap down there. So that is something we do not want to see because that could be a bad thing. So how do we get around this? The PinkWave curing light has many different wavelengths. So it is a poly wavelength light. It has your blue for your camphor quinone photoinitiators. It has a purple light, the UV, for the UV photoinitiators. Then it has a red light to enhance the polymerization of our composites. And then way over to the right where you have the near infrared, that wavelength from about 800 to 900 nanometers, that enhances the polymerization. And by enhancing, what it means, it gives us more depth and it actually decreases polymerization shrinkage by up to, some studies have shown, 26%. So we can eliminate that shrinkage that creates that microgap down at the bottom of our box by doing a couple things. One, not overfilling our restoration so we don't get that large volume of composite that undergoes that polymerization shrinkage. And that's why typically we'll place our composite in layers, right? So the volume is less and the total shrinkage is minimized. But when we place that composite, whatever bulk it is, and we use this curing light. We've got 4 different wavelengths, so we get all the different photoinitiators to be activated. But that near infrared gets the molecules moving, so when they're kind of cured in that composite restoration, there's less polymerization shrinkage. And that is an important thing that I don't know any of the light that can render that kind of solution to our polymerization shrinkage. There's also 4 different modes of curing that the PinkWave has. We have the boost mode, which is a 3-second cycle, about 1700 milliwatts of power output. Then we have the ramp cure mode, which gradually increases in intensity and then stays at about 1500 milliwatts per centimeter squared. Then we have the standard cure mode, which again is a 20-second cycle, and every 5 seconds you'll hear the PinkWave beep. And that again is about 15 milliwatts per centimeter squared power output. And then for diagnostics, the PinkWave has a transillumination setting, which means it's basically white light, but a very intense white light that helps us find cracks. And we'll talk about that a little bit more. So we have 3 different curing modes: boost mode, ramp, and standard. I typically just use standard. And then we have a transillumination mode. Now the head of the PinkWave is very low profile, comes out about 90 degrees to the handle of the PinkWave. And I can get back to second molars very easily without the patient having to open really wide. I can get back to third molars. The PinkWave can deliver. And because we decrease the shrinkage of our materials, we have decreased marginal staining, lower chance of microleakage and secondary decay, which is a benefit to our patients. We have reduced patient post-operative sensitivity. I had some of our key opinion leaders that have used this light tell me all their sensitivity went away when they switched over to the PinkWave. And that reduction in polymerization shrinkage comes from the near infrared wavelength that the PinkWave has. And I don't know of any other light that has that near infrared. We get a better cure, so we have harder restorations, which means greater wear resistance, meaning our restorations will last longer. And because there's less microleakage, there's going to be less water absorption. So the PinkWave has the high intensity light, it's collimated, and it's just able to deliver that light in a way that we need it to. Now, I just want to tell you about a new development. The PinkWave recently has had 3 different tips developed for it. The PinkWave tacking tip, which is a 2.5 millimeter diameter tip, interproximal diagnostic lens that can focus that bright white light to about a millimeter surface area so we can transilluminate teeth and find the cracks. Then we have a tight contact curing ball, which we can place into our box form, press our matrix up against the adjacent tooth, cure a composite. So now we know we have that tight contact, because I know I talked to some clinicians and they're challenged with getting tight contacts. And so now you cure with the PinkWave. So we've got these little tips. They slip right onto the head of the PinkWave very easily. Let me just show you really quickly how that's done. And you can see now that bright white transillumination light is concentrated to a 1 millimeter little tip, and it helps us to find cracks in teeth. You know, if the patient comes in and says, you know, when I bite down this tooth is sensitive, and you visually look at it and you can't see anything, I can get in there and transilluminate and tell the patient, oh yeah, you know, I can see a little crack in there. That could be what's causing that sensitivity. So that's a very useful tool to have that diagnostics. Then we have the tight contact curing ball tips, which again go on, and you can see it has that ball tip. So now we make sure that we have our PinkWave in a curing wavelength, so it's going to look more pink. And what I do is I take, we've talked about this before, seam-free composite wetting resin. I put a little bit on that curing ball tip, and then I put my composite in the box, and then I place that tip into my composite, and I push that ball up against the adjacent contact, and I cure that for 5 or 10 seconds. And that assures us that we get that tight contact. Now what I try to do is I try to make sure I don't push the ball into the composite where it's totally surrounded, because remember, this ball has an undercut above it, and if you place it into the composite where the composite goes over the top of that ball, you may have some problems getting that ball tip out. So again, just push it into the composite on the top part, so the bottom half of the ball is in the composite. Push that matrix up against the adjacent tooth with that curing ball and then cure for 5 to 10 seconds. Now, this is one of the favorite tips that I use every day. So it's a tacking tip. The tacking tip is that 2.5 millimeter diameter tip. And what I do is I place my restoration, whether it be a crown or a veneer, and I wipe off the excess at the margin, and then I tack it for about 3 to 5 seconds. And what that does, it seals that margin. It makes it so that restoration can't move. And then I can clean up the rest of the composite. I can floss, I can wipe off the rest of the composite everywhere else, and then go back to this one area and polish it down. And it makes my cleanup so much faster because I don't have a lot of excess. So here's some crowns I placed, the two centrals. You can see there's some excess material that's coming around. I wipe off that excess and then I come in with my tacking tip pointed up at about a 45-degree angle. So by doing that, I don't cure all the composite interproximally. I only cure that 2.5 millimeter area of composite right at the gingival margin, so I don't have to worry about crevicular fluids anymore, and I don't have to worry about that restoration moving while I clean up the cement everywhere else. So I seat the restoration, wipe off the excess, tack with my tacking tip at the gingival margin for 3 to 5 seconds, pointing that light up at about a 45-degree angle so it's not going into the interproximal areas. Then I can floss the interproximal areas. I don't have to worry about that restoration moving because I've already secured it at the gingival margin. Wipe off all the excess on the lingual. Floss again just to make sure I get it all done. And then I cure and then clean up. It's a really easy recipe to make that work. Another thing I really like about the PinkWave is if I'm doing these really large teeth, whether it be a molar or a long central, that head of the PinkWave is a little bit over 12 millimeters, so it can cover the entire surface area. Before, when I had like a 7 millimeter or 5 millimeter diameter tip, I'd have to do the gingival margin, mid-body, and then the incisal. Now I cover the whole restoration, whether it be an occlusal on a molar or a crown or a veneer on upper central. I cover the whole thing with the light, and I can get the curing done much faster. So what are some of the great things about the PinkWave curing light? 8.5 millimeter depth of cure. It's got the transillumination. It's very lightweight, not heavy at all. Has that large lens so I can cure teeth in one cure, 20 seconds. It has a lot of forgiveness because the way it's focused, I can keep that light about 4 to 5 millimeters away from the restoration, away from the patient's gum. Because one of the things is it's so well collimated, and it's such a high intensity light that if you get this light close to the patient's gums, they'll tell you, hey, I feel some heat there if they're not numbed up. So I tell them it's a high intensity light. We're trying to get the light through the restoration to cure that cement. And so if you feel any warmth, just let me know and I can pull that light away. Or you can create a little space between the restoration and the head of that curing light and have your assistant blow some air in there, and that'll keep it cool. We have this collimated beam, so we focus the light so we don't lose the light, doesn't splay out. Very safe to use because the PinkWave curing light, that energy is not absorbed by the pulp. And so we're not going to overheat the pulp, even though it's a high intensity light. And I know that's something that clinicians worry about, but in this case with the PinkWave, it's been tested. It will not raise the temperature of the pulp to a point where you're going to cause any type of injury. And it's very low profile, and that low profile is important for me to get back to the back teeth and not have any kind of shadowing. So the PinkWave curing light is a light kind of in a class of its own. It has different wavelengths than the other lights, and because of that, it can perform better than other curing lights. Now, I hope I gave you some tips, so if you don't have a PinkWave yet, you can cure better. You'll have less sensitivity, longer lasting restorations, and happier patients. So remember, make sure that you keep that light close to where you're curing. Don't have it way far away. Make sure you come in over your restorations or your preparations so you don't have any type of shadowing. And make sure that you have the proper wavelengths so that you are actually curing the photoinitiators in your different dental materials. If you follow those 4 points, you're going to have great success in your curing. And if you have a chance to get a PinkWave curing light that has the high intensity, the different modes of curing, the transillumination, the low profile, all the things that I want to have in my curing light, then I think that's going to make your life much easier. So check out the PinkWave curing light. Now, I hope you like this information. If you did, hit the like or hit subscribe so you know when we are posting more of these programs. And I just want to tell you, we're creating this community of like-minded individuals committed to doing the very best for our patients. And I enjoy sharing this information with you. And if you have any comments or questions, please send them my way. All right. Thank you very much. And I will see you during our next program. Take care.